So let's return back to our benzodiazepines and let's talk for a moment on the metabolism or the biotransformation of these drugs. For this category of drugs, almost all of the benzos require the liver for biotransformation. There are three in particular that are metabolized outside the liver, and coincidentally the acronym OTL, outside the liver, also stands for the three drugs that are metabolized outside of that liver: oxazepam, temazepam, and lorazepam. And so what does that mean clinically? Well, these are the three drugs that are safe in patients that have liver disease or liver failure. So this is almost always asked on step one. I made it into a learning objective as well. You need to know it. It'll be asked at some point. Other reasons for the extended half-lives that we see with some of these benzodiazepines include excuse me, enterohepatic recirculation. So essentially the drug basically gets activated by the liver, and then it just basically recirculates through the hepatic, what's the vein? The hepatic portal vein, and then just kind of goes through the digestive system as well. And then you can see several active metabolites, many of which are biotransformed or conjugated by numerous CYP enzymes. And so all that kind of leads into the notion that some of these benzodiazepines, once they go into the brain and then they leave, they can kind of recirculate and persist within the periphery. And so you can measure them in the serum for upwards of 90 to 100 hours after the first dose was administered, but the patient's not going to experience any sedating effects because the drug has long left the brain. So what are the clinical uses of benzodiazepines? Acute anxiety states, and so back in the 1960s, I think I talked about this in the previous lecture. We basically called these diazepam or Valium tablets mother's little helper. We see them prescribed almost routinely in a couple of weeks for almost every dog in the neighborhood for the 4th of July. And we've used them for patients almost routinely for surgical procedures where we'd want to invoke not only sedation but a little bit of amnesia as well, and so you can see them used for colonoscopies as well. They fit into this lecture because they work quite well for panic attacks. They have been used in the past for insomnia and sleep disturbances, although one could argue there's other drugs out there. And of course, we had talked about benzos in the context of seizures. What we haven't talked about are some of the side effects of benzodiazepines. And so when the drugs are used alone or acutely for short-term durations, like 4th of July, colonoscopies, and so forth, we see minimal side effects. And in fact, these drugs are quite safe. They've got a large therapeutic index. There is some feeling of grogginess the next day, which is relatively minor. There is a little bit of amnesia as well, which could be good or bad. If the dog wakes up on the front porch and they can't remember how they got there, that could be bad for the dog. Most of us, I think, would rather forget having a colonoscopy, so the amnesia is a good thing. But as we said earlier, there can be numerous drug-drug interactions, especially with other drugs that are working on the CNS. So relatively safe, minimal side effects, but some things to look out for. Where we see major side effects or problems with benzodiazepines is the chronic use of these drugs. And so when you chronically administer these drugs, you get a CNS state of depression that basically is an extension of these drugs. And there is some notion, although it's somewhat debatable, in terms of the dependence liability. So are these drugs addicting? The problem is that when you start combining benzodiazepines with other drugs, and the main drug that produces the most problematic outcome is alcohol. Okay, and so benzodiazepines in and of themselves have a large therapeutic index. Okay, And they have what's called a respiratory ceiling effect. And so this is respiratory depression. And as you go up on this axis, you are closer and closer to death. Benzodiazepines by themselves, when administered orally, never typically reach the danger zone because of their large therapeutic index. And remember I said as the dose of benzodiazepine is increased, the availability of GABA is reduced. And so that explains part of the respiratory ceiling effect. However, when you combine benzodiazepines, even orally administered benzodiazepines with alcohol, that respiratory ceiling effect gets bumped up dramatically, closer to the danger zone. Okay? When you give IV benzodiazepines in the context of maybe an epileptic seizure, that has the smallest therapeutic index, okay, and in overdose situations can lead the patient very quickly to respiratory depression, okay? And so it's because of these drugs, or these drug combinations, that we need to provide a potential antidote to benzodiazepines. Typically not for these patients down here, but for these patients up here. Specifically this group of patients right here that is self-medicating or abusing alcohol with their benzodiazepine prescription. And so in the context of an overdose, we can give a GABA antagonist called flumazenil. Okay? And so what this drug does is it binds to the benzodiazepine site on that GABA receptor, and it prevents GABA activity. And so it competes with benzos for that site and basically removes it from that receptor. Okay? Now, if this is an antagonist, that means that it doesn't open the receptor. So the benzo would actually open the receptor and provide chloride to move in. The antagonist would go into that receptor and close it, so no chloride enters. Okay? And so why do we even need this? I mean, how many patients are combining benzodiazepines with alcohol? Well, lots, actually. It's the easiest way for a suicide attempt, unfortunately. And patients that go to parties and are on benzodiazepines maybe for anxiety will inadvertently or advertently mix them with booze and possibly other drugs, both prescription or recreational, and they can very quickly go into a respiratory depression. And then chronic use in benzodiazepines is somewhat problematic. There is some argument in the field as to whether or not these drugs produce dependence. And so a lot of this really comes from the definition. And so this is a little bit ahead of the game, but I think Dr. Dance will do a much better job talking about dependence liability in a couple weeks. But understand that there's psychological dependence and there's physical dependence. Okay? And with physical dependence, and you can read the definitions there, we're really kind of distinguishing between tolerance and withdrawals. Okay? And so with physical dependence, you can see an increase in drug taking, which means less drug action, and the persistent need to take more and more drug. That's tolerance. When we stop the drug intake, the physiology is disturbed, and we experience withdrawal symptoms. And so this will be kind of elaborated on in the drugs of abuse lecture towards the end of the block. Excuse me. But what's interesting is that the benzodiazepines, they don't really stimulate the areas of the brain that we traditionally associate with addiction. Okay? And so are we saying patients are being dependent upon them? So they're requiring them because they're part of their routine? Or are they truly addicted that basically involves a rewiring of brain chemistry centered really around dopamine? Okay? And so we can talk a little bit more about this in detail in a couple of lectures, but I just wanted to kind of bring it up as an introduction. This was our long session on benzodiazepines. If you have any questions, please email me, and we will go on to the final group of drugs, the monoamine oxidase inhibitors.